Okay, so here is the rest of Learning Plan 2. We're starting with slide number 45, and we're talking about anti-anxiety and hypnotic drugs from Varkarolus, Chapter 3. Now, again, I don't have Chapter 3 assigned, but you might want to reference like this information on the on this class of medications is on page 49. So, in case you wanted to kind of look it over a little bit. So, benzodiazepines. So, those are things that we think about to help with anxiety disorders. However, the biggest problem that we have with these benzos is that they are very addictive, and many times people take more than what is prescribed, and they can end up, very sedated, especially if they mix these medications with other CNS depressants, including alcohol. So we really have to be very careful. They are very, very addicting medications. As a matter of fact, just as a point of practice, I've really noticed a great decrease in the amount of benzos that physicians are prescribing to patients on 1K, much preferring other types of anti-anxiety medications. Atarax is one that they use pretty frequently. And the other thing is that we are always asked, and it's even now right in the MAR, we're asking patients to try at least one or two coping mechanisms before they get the PRN. So usually when you offer somebody a PRN, or they're asking for a PRN of usually it's clonazepam or alprazolam, lorazepam. Those are kind of the common ones that we would give. We usually ask people, first of all, to rate their anxiety level on a scale of 1 to 10. And then we would ask them what they have tried to reduce their anxiety first, before they get the PRN. And usually people will be pretty honest and say that they tried their deep breathing techniques, or they tried distraction, they tried reading, any number of different things. And if they're still truly suffering, they've tried a couple of different things, and they don't have Atarax ordered, perhaps then the physician is okay with them getting their benzodiazepine. But we really do have to be pretty careful. So they can cause respiratory depression, usually in higher doses. So we're probably more concerned with that if somebody is not in the hospital and they're just taking it on their own. And again, people sometimes don't take what's prescribed. They take more than what's prescribed. So we might worry about some respiratory depression there. But usually in the hospital with just a small dose and given every 4 to 6 hours, we wouldn't really worry too much about CNS depression and respiratory depression. It's when we are giving higher doses, such as when somebody is going through alcohol withdrawal and we're giving them lorazepam 2 milligrams every hour. And sometimes that 2 milligrams is even given IV push. And if it's given 2 milligrams every hour for a high CWA score, which is what we use to measure alcohol withdrawal, we can be giving an awful lot of Ativan in a short amount of time. So we could be giving 10 milligrams of Ativan in a couple hour time period. So then we might have to really worry a bit more about respiratory depression. But for the most part, that isn't, terribly what we're worried about with just normal small doses. The medications on the right-hand side, starting with Dalmane, flurazepam, those are usually used for sleep. We do not give sleeping medication during the day. And you might think, well, that's obvious. Why is she even saying that? But there are times in clinical when a patient will ask for a sedative medication, such as the ones listed on the right-hand side, during the day, because they haven't slept all night and they really feel like they just are so sleepless that they just need some sleep. And so we will get patients asking for sleeping medications during the day. And truly, we don't give them. We would much rather give them maybe something if they need a benzodiazepine, a small dose, something to maybe help them relax and sleep a little bit, or maybe just get a nap in. But we certainly don't want somebody sleeping soundly all day long, because then they're going to be reversing their sleep patterns. So it really is, something, I think, a point worth mentioning, that we don't give those medications on the right-hand side during the daytime. Overall, some patient teaching with benzodiazepines would be certainly to encourage the patient to take the medication as prescribed, and only if needed. Usually, if a physician even orders it for them to take it at home, we would really want to make sure that the patient understands only to take the prescribed amount, and only if needed. I know somebody who was an older person who actually saw that the label said, take 4 times a day PRN, thinking they needed to take it 4 times a day, regardless of how they felt. So to make sure patients really understand what PRN means is pretty important. And also, of course, to see how they respond to the medication in terms of operating machinery, driving. We should certainly encourage patients to use caution with these medications until they kind of see how they. Sometimes, if somebody is on a medication like this, kind of for an extended time period, they may adjust to it to the point where they can safely drive or operate machinery. But you really have to be pretty careful when people are first starting out these medications. And ataxia is actually a very common side effect too. So we have to make sure that people's, if they have another condition that causes a gait disturbance, we might be a little bit worried about them staggering around a little bit and getting hurt. So, all right. There are also some medications, short-acting sedative hypnotic sleep agents, the Z hypnotics. So Ambien, Sonata, and Lunesta are the 3 that are listed here. And Ambien is most commonly prescribed in the hospital. I see that used actually quite a bit. The problem is, I have also seen many, many side effects with Ambien. I really don't see Sonata or Lunesta prescribed much in the hospital. But the thing to know about this classification of medications too is that they do have those sedative effects, but they don't have the anxiety, anticonvulsant, or muscle relaxant effects of the benzodiazepines. So they work just a little bit differently. They just really are to help people sleep. So they do have a lot of potential, though, for amnesia and ataxic side effects. So again, we have to watch their gait. When somebody takes their, most important thing is, if somebody is ready to take their Ambien, we should make sure that they actually are going to bed, that they're not going to be up and walking around the unit when they're in the hospital. When they're at home, and it's very important to stress that too, that they take the medication and they go right to bed, that they should not take their Ambien and then drive to McDonald's to get a burger while they're waiting for the medication to effect, thinking that they have enough time. Because literally, that is a true story, and a patient ended up in a car accident because they took their Ambien and then decided to drive to get a snack and then think they could make it back home before the medication took effect, and they were wrong. So, and the other thing with Ambien, again, people kind of if they're wandering around their house, they can fall down a flight of stairs because they become ataxic. And the other side effect I've noticed too in the hospital is that it really can alter some patients' mental status. Somebody who came in with not having any type of psychotic disorder, I think they just had basically a simple depressive episode, but they took Ambien at night, and then sometime during the night, they were found underneath their bed, thinking that they were fearing that they were being attacked by pirates, and they were on a pirate ship. So really some people can have some really strange reactions to Ambien. So I think in the hospital, we certainly have to watch them very carefully. When they're at home, we really have to do that, stress that teaching that they take the medication, go right to bed. They do not want to be driving or doing anything around their house because they may really have great potential for injury. The other classification on the right-hand side, the melatonin receptor agonists, so Rosarum, Silanor, Buspar, those are some other medications that can be used. Buspar, in particular, we use quite a bit for anxiety in the hospital, and many patients are also sent home on Buspar. The great thing about Buspar is that it is not addictive. So if we want somebody to experience relief from anxiety, but we don't want them addicted, like you become with the benzodiazepines, Buspar is really a great choice. It does, however, have to be taken on a regular basis. You do not take Buspar PRN. It doesn't work that way. It has to build up in your bloodstream the same way that an antidepressant does in order for it to work effectively. So it has to be taken on a regular basis, no matter how they feel. It's not something that you take and you experience quick relief like you do with a benzodiazepine. Something else, too, I want to point out about the Rosarum is that it is not a scheduled substance, so there is no abuse potential for that, and it works with melatonin and kind of regulates the circadian rhythm, kind of works that way. And Doxepin is actually, it's a low-dose formulation of a old tricyclic antidepressant. So we'll learn about that, talk about that a little bit more in Learning Plan 3. But as an old antidepressant, one of the major side effects of Doxepin was sedation and sleepiness. So given at night certainly is very helpful, but it's a pretty low dose that it is given in this for this classification. The only problem would be that if you have urinary retention already, or you're on monoamine oxidase inhibitors, then you should avoid that medication. And again, additive CNS depression with other medications or with alcohol can really be quite a bit of a problem. Okay, advanced practice interventions. So, for anxiety, cognitive therapy, so helping people to think about their anxiety level, their problems, their reactions to stress, and just kind of really moderate it. If you can change your way of thinking, that can lead to changes in behavior. There are different types of behavior therapy, relaxation training, modeling, systematic desensitization, flooding, response prevention, thought stopping, and cognitive behavior therapy. These are pretty much considered advanced practice interventions, so not necessarily something that you would be doing in clinical. However, thought stopping is one technique that sometimes as a staff nurse that you're able to teach a patient. And these techniques are kind of outlined on page 290 and 291. So thought stopping is kind of a nice technique to use. It's really very simple. And either you train the patient to either say stop, or to like wear a rubber band around their wrist and kind of flick the rubber band every time a compulsive thought or an obsessive thought kind of comes to their mind. They kind of say that word out loud, stop, or they flick the rubber band and kind of causes a little stinging pain on their wrist, and then like count back from 10 and kind of refocus. So that's something that you could probably use in clinical, but literally the other ones are very much things that you need training for. So just think about flooding. That would be basically you're exposing the patient to a very large amount of something that is going to give them a huge anxiety response. So just think about if you had a phobia about snakes and you literally were put inside of a cage filled with snakes and you were locked in there and you had to stay there and you couldn't get out. So think about the anxiety level you would experience. You really have to be a trained professional to be able to do those types of techniques, and even systematic desensitization where you're slowly, instead of putting somebody, flooding is just like you're just immersing them in the thing that they're so fearful of. But systematic desensitization is systematically exposing them, like, slowly to the thing that they're phobic about. So maybe if they're, again, phobic about snakes, then they would start with showing them maybe a picture in a book about snakes, and then they would just have to look at the picture briefly. Then maybe they have to look at the picture for 5 minutes, and then maybe they have to touch the picture, and it's going to gradually get them to the point where they can actually be in contact with a real snake without having that anxiety response. So they're all really interesting techniques, but truly things that a trained advanced practice nurse or a psychiatrist or psychologist would be doing. So we always, as nurses, need to evaluate. Is the patient experiencing a reduced level of anxiety? Does the patient recognize their symptoms as anxiety related? That's actually kind of important. So it's really helpful for people to develop insight into their illness and into their symptoms, because many times people will continue to feel like they have perhaps a medical problem going on. And really, they don't. It's their anxiety level. So if they really recognize their symptoms as anxiety related, it can be very helpful, because they may continue to feel like something medically is wrong and we need to find out what it is. And if they kind of persist on that, then they're going to be resisting anything that we're trying to do to help them to manage their anxiety level. We also want to look at, does the patient continue to have signs and symptoms such as their obsessions, compulsions, phobias, excessive worrying, or other symptoms of anxiety disorders? If they're still present, are they more or less frequent, more or less intense? So again, many times when we're evaluating, most of these things are very subjective. Yes, there are objective signs of anxiety that we can recognize. I mean, we can notice how often a patient is washing their hands or using a Kleenex to touch doorknobs. There are things we can look at. We can see if somebody is visibly tremulous, shaking, sweating. We can see all those things, but truly, much of anxiety is really very subjective. So it's the person's own experience. So we do try to help people to rate their anxiety on a 1 to 10 scale. Again, the same way as we do pain. Probably, I have a little trouble with that pain scale too, because I do think that sometimes people feel like they have to say it's a 10 in order to get their medication. And if they're not really showing a lot of, visible signs and symptoms, and they're saying it's at a 10, and they're drinking coffee and talking on the phone and, looking pretty relaxed, and it's kind of hard to really think that that's a 10. I do think that some teaching needs to be done with using scales like that. So in the same way as the pain scale, I think the anxiety scale, if someone says their anxiety is a 10, honestly, it probably isn't unless they are in a panic attack. And if they're having a panic attack, they're not likely to be able to tell you my anxiety level is a 10, because they're so focused on how they feel, they're not perceiving what's going on around them. So if somebody says their anxiety is a 10, probably isn't quite accurate. But so, we do have to do some teaching when we're having patients use these rating scales. So we have to also evaluate if the patient is able to use newly learned behaviors to manage their anxiety. They really learn a lot in group therapy when you're in clinical. So I highly recommend that you go to group as often as you can and really see what the therapists are teaching the patients as far as learning to manage their anxiety. They truly are trying to give them a toolbox that they can draw from when they feel anxious. The other thing to really take a good look at is, does the patient adequately perform self-care activities? And we can't take that for granted that people will just automatically shower, wash their face, brush their teeth, comb their hair, groom themselves appropriately, because when people are anxious, they don't. Sometimes they truly neglect their own hygiene. So that is a very important thing to be looking at. Can they maintain satisfying interpersonal relations? It's hard to have a relationship when you are very focused on how you feel and your anxious feelings and your phobias and your fears or your compulsions. Very, very difficult. And can the patient can they assume their usual roles? So can they function? I've seen people that are very high functioning, brilliant people that are, engineers and all different types of they have great careers, but because of their anxiety level, they're not able to function. They can't perform in their usual role. They miss a lot of work, or if they go to work, they're not functioning at their highest capacity. So this slide, just to throw in a little bit of QSIN for you, quality improvement. So this is a scale. You don't really need to know, any details about this, but just to know that there are scales out there that develop outcomes and guidelines for care of people with anxiety, and that we do have to monitor their progress, and that's a very important part of treatment. So just for an example, after 6 months of treatment, 50% of patients with severe anxiety disorders will score less than 3 on the CGIS. That's all you don't really need to know anything specific about that scale, but just to know that we do use quality improvement measures in mental health nursing. Chapter 16, trauma, stressor-related, and dissociative disorders. So, trauma-related disorders in children. So, when we're looking at this clinical picture, we're thinking about post-traumatic stress disorder, or PTSD, in preschool children. There's something called reactive attachment disorder and disinhibited social engagement disorder. So PTSD, yes, can happen in children, absolutely the same as adults. And it's probably easy enough to think about situations that can cause PTSD in children in terms of kids that are abused and neglected, and just, maybe come from just really difficult family backgrounds. So they have symptoms that are pretty similar to adults, except that obviously developmentally they are displayed a little bit differently. So overall, we really have to understand that traumatic life events are really associated with a wide range of psychiatric and other medical disorders. And thinking about children specifically, that they really don't have the coping skills and they can't sometimes defend themselves. And so they really are at very, very high risk to have trauma from these traumatic experiences that they're going through. It is great that we are now really starting to understand, and there's really studying the effects of trauma on children and adults, and that trauma-informed care is something that's trying to be integrated into all healthcare settings. Maybe you've heard that term or maybe you haven't, but I keep hearing it over and over again, and it truly means that we are taking into account the person, their own personal trauma, what they have been through, and really trying to understand that that's where they're coming from. And if we include that in their treatment, then they're going to get much better care. It really is difficult to try to treat somebody and ignore that part of their life. You really can't, because what they've been through is just very, affects them very deeply. So let's look at what is reactive attachment disorder, because maybe that isn't something that you've really heard about. Children that have this reactive attachment disorder usually are pretty withdrawn. They don't attach to significant adults. They usually haven't had that experience. So many times it's a result of lack of bonding, again, because of abuse, neglect, or sometimes because the child has been in an institution and they haven't really bonded with an adult, usually by the age of 8 months. So that lack of bonding is really very significant. And they have just very again, emotionally withdrawn behavior. They don't seek comfort from adults, and they don't look to adults to get their needs met. So they're very withdrawn. Disinhibited social engagement disorder is kind of the opposite response. And that is the child can actually come across as being really friendly and confident, and they have no normal fear of strangers. They are willing to go with anyone. And that is very scary too, because they are very likely then to be, they could be sex trafficked, they could be abducted very easily because they seem like they're so trusting and willing to just to go with anyone. So that's really, very, really kind of dangerous. So they're actually, by attaching to everyone, they are not really attaching to anyone. So again, just something that's very, very problematic in children. So the causes of all this. So genetic, how individuals react to trauma. Again, much of that is genetically determined. Neurobiological, we can think about the pathways that integrate emotional regulation, triggers hypoaroused state leading to dissociation. So sometimes, trauma definitely can cause changes in the brain. There's lots of different theories, and environmental factors certainly, that we have to again think about children as being dependent on adults and systems. So they're dependent from other people to get their basic needs met and to get their not only their physical needs but also their emotional needs that are going to help them to grow and to meet each developmental task. So they aren't able to do that on their own. That's just the way it is. So that really makes them much more prone to have difficulty. So that's a huge environmental factor. And there can be other external factors that can support or add stress. So of course, looking at the child's living environment is a very important thing to think about as the cause of some of these types of disorders. If you look in Vacarolis on page 298, 290, and 299 especially, the information gets really, really detailed as far as what's happening in the brain, different types of responses in the brain, myelated, unmyelated. You don't really need to get that specific. Just really read through that kind of quickly. It's really just to get a good basic understanding of how complicated this all is. And also, if you think about a child in general, that the most rapid phase of brain development occurs during that first 5 years of life. So a child is really vulnerable to adverse events that are happening. And a child is really most vulnerable to things happening in that first 5 years. We'll talk about child abuse a little bit more in Learning Plan. I think it's Learning Plan 8, if I'm remembering correctly. But anyways, we will talk about this kind of whole concept again, but usually birth to like 3 years old, especially, children are at very, very high risk for abuse and neglect. So again, if we think about how much is going on in their brain, how quickly their brain is developing, so really very detrimental to the brain and to the child when difficult things happen at that part of their life. So we're always applying the nursing process. So we're always doing, as part of our assessment, we really want to make sure we do that developmental assessment and see if the child is meeting the tasks that they are supposed to for their age of development. Of course, that Denver 2 assessment is really good to be used for children up to 6 years of age. There might be some other tools available for older children and adolescents, but it really is important to think about recognizing those abnormalities and trying to get the child help as early as possible so that maybe they won't develop a psychiatric illness as a result of what they've been through. We're always looking for different types of nursing diagnoses that when we're working with children. So we could be thinking about issues that would warrant a diagnosis, such as anxiety and substance abuse in the parent. So we might be thinking about separation. We might be thinking about parental conflict. So lots of different risk factors are going to aid us in thinking about which nursing diagnosis is the best one to use. So we're always using the nursing process. We're identifying goals. We're looking at the implementation, which is the interventions that we use, and we're, of course, always evaluating. Another aspect to really think about too is that you can't just work with the child. We really have to think about working with the whole family. If you take care of the parents, then in turn, you're also taking care of the child. So it really does get very, very complex and really needs to involve the whole family. So interventions, again, this is what we do as nurses when we're working with children. Stage 1, provide safety and stabilization. So very, very basic needs. Stage 2, reduce the arousal and regulate the emotions through symptom reduction. So we want to help them feel better. We want to help the child to feel less anxious, to feel more comfortable, to feel safer. In stage 3, then, later on, catch up on developmental and social skills and develop a value system. So these are things that we can do, the ways that we can intervene to help the child to hopefully to avoid developing a mental illness in their future. So interventions for child with PTSD definitely establish trust and safety. So how do you do that? That would be the goal of nursing, to really establish trust. And think about how you would establish trust and safety with any patient. You want to always communicate very clearly who you are, what you're doing. Make sure you explain things before you do them. Read the patient, kind of see where they're at. If they're looking really fearful, maybe you need to stop what you're doing and explain more and get them comfortable. Have a conversation with them about what's going on. Ask them how they're feeling. So sometimes, we're busy as healthcare workers, and it's easy to just kind of plow ahead and say, well, I need to get your blood pressure right now. And the patient's looking upset and frightened and confused, and we really need to think about establishing trust and make sure that that person trusts us and feels safe and comfortable. Using developmentally appropriate language with children, of course, is very important. It is important with all ages, but just think about children who just haven't learned some of the terminology that we have as adults. We should always try to use language that the patient understands. We can teach older children relaxation techniques. We can use art and play to promote expression of feeling. So have a child draw a picture, give them a doll to play with, and sometimes they can act out the thing that's bothering them in a way that's safe and comfortable for them, and it really does help them. So we can involve the caretakers in their one-to-ones unless they're the cause of the trauma. So it would be great if all caretakers, parents were supportive and helpful, but that isn't always going to be true. So we always need to educate the child and caretakers about the grief process, if that's appropriate, and assist the caretakers in resolving their own personal distress, and coordinate with social work for protections, especially if there is need for child protective services to investigate something that might be happening in the child's home environment. So on page 300 and 301, there is a really nice paragraph that outlines the interventions that can be used with children. So, children really do need help with dealing with different types of symptoms like flashbacks possibly, or amnesia, or even hallucinations. They may have developed an imaginary friend as a coping mechanism. So there are ways that we can communicate with a child. So, such as they give a really nice example in your book. Sometimes when really bad things happen, our brain helps us by forgetting and creating a special part of ourselves that we might think of as friends. Yeah, that may sound like it's a little complicated for a child, but I suppose if you kind of, um, make that a little bit more simplified, that could be very helpful. So these traumatized kids really need to learn strategies to regulate their emotion, their anxiety levels. So teaching some of those deep breathing, mindfulness techniques, warm baths, singing, distraction, listening to music, guided imagery, all those things can really be very helpful to kids. Post-traumatic stress disorder in adults. So you're probably more familiar with this, and I am pretty sure that you could probably come up with some situations that would cause post-traumatic stress disorder. So I'm hoping that you're thinking of things that are, of course, traumatic, and it could be interpersonal trauma, something that happened to you yourself, or it could be something that you have witnessed in another person. Even if you witness, say, a serious car accident or a train crash or something, and there's a lot of lives lost, that could be something. Even if you weren't hurt, you have witnessed something, and that could be part of post-traumatic stress disorder. So it doesn't always have to be something that happens to you. And it also can be something that happens as a result of a natural disaster. If you have ever been in a hurricane or near a volcanic explosion or anything like that, a tornado perhaps where there was a lot of devastation, a flood, that can certainly cause symptoms of post-traumatic stress disorder too. And actually, being in the military, sometimes police officers, and honestly, nurses can have PTSD depending on what area you're working in. Perhaps nurses that work in trauma or work in emergency rooms can possibly also develop this disorder. So you might think of some other occupations or situations that could cause PTSD. So basically, the symptoms that we're looking for always that we're assessing are that the person is re-experiencing the trauma. They avoid stimuli associated with the trauma. They have persistent symptoms of increased arousal, and they have alterations in their mood. So they are re-experiencing the trauma. So sometimes they might hear like, oh, fireworks or something could be something that could set somebody off that has PTSD, if especially in the military, if they have, maybe it reminds them of bombs going off or a car backfiring, some kind of a loud noise, could trigger something. Or sometimes what happens with people is they can just be sitting in a room and doing something, watching television or reading a book or something, and all of a sudden they just have that kind of a flashback of being right there again and experiencing whatever it was that was traumatic. So avoiding the stimuli associated with trauma. So perhaps that person who is triggered by fireworks won't go to fireworks at the 4th of July. They're going to try to travel somewhere else, maybe go out of the country, so they're not going to be anywhere around 4th of July fireworks. There's a lot of different things that you can do. If you are attacked in a park, and maybe you will just never go to that park again, or if something happened to you in a parking lot, maybe you're going to avoid driving your car to a parking lot again. I don't know. There's just lots of different things that we can think of that, people are just going to try to avoid that stimuli. The symptoms of increased arousal certainly are, think about anxiety symptoms, think about your heart pounding and being on edge and having, like if somebody tiptoes up behind you and calls your name softly, you jump, you have like a hyper startle type response. And certainly alterations in mood, people can become depressed and anxious. So this is a comic strip. It's really not a funny comic strip. It's actually very poignant. This is somebody who is a military person, and the other guy is saying, "Thank you. What would you like for Veterans Day? Like, thank you for your service." And basically, he's saying a key to unlock that huge weight, that burden of PTSD. So this is actually really quite accurate for people that struggle with PTSD. And there's a really great sentence in your book at the top left-hand corner of page 303, and it says, victims who suffer from PTSD begin to feel permanently damaged and often hate themselves for feeling so needy and helpless. So it really is something that can be really very devastating. We've seen patients on 1K that have PTSD, and they really, truly struggle very, very greatly with their symptoms. There are specific treatments for PTSD. It isn't all hopeless, but it may be something that people have a great deal of difficulty seeking help for. Think about it throughout history. I can think of examples like the Holocaust. And the reason I think of that example is because when I was living in Rochester, New York, I was an advanced practice nurse working at a Jewish nursing home as a psychiatric consultation liaison nurse. And so my role was to work with the patients that were at the nursing home or the residents, and work with the staff, because the staff sometimes had difficulty with some of the residents' behaviors, not understanding that they had PTSD. And it didn't matter if these residents were in their 80s and 90s and they had been through the Holocaust and they had seen their whole families killed. The staff sometimes thought that, well, that was a long time ago, they should be over that. I can't believe that they're still bothered by that. Well, I had to do a lot of education. As a matter of fact, I spent a lot of my time reading over the residents' charts, and it was just horrifying, some of the things that I read. I just remember this one lady that her entire family was shot and killed right in front of her eyes, and her husband and all of her children. She survived. She was in a concentration camp. She lived. She ended up coming to the United States, getting married again, having a bunch more children, working, and just kind of going on with life and never getting treatment for PTSD. I truly don't think any of those Holocaust survivors got treatment for their PTSD. And they just started new lives and started new jobs, new careers, new families. And now they're elderly and they're in a nursing home and they're having symptoms. They're having depression, they're having anxiety, they're having behavioral problems. So my job was to try to help them, to try to come up with some interventions that would help them to reduce their feelings and their anxiety, and also to help the staff to interact with them more therapeutically, and really get an understanding of what they were going through. So I really think this is very poignant. It is just like this huge ball and chain that they're carrying, and sometimes it really is very difficult to get rid of. So this guy just wants a key to get rid of that shackle around his ankle. So, all right, that's PTSD. So we really have to think about, again, using the nursing process, identifying outcomes, and the goal certainly would be to manage their anxiety level, to increase their self-esteem, improve their ability to cope. And we are using that same kind of three-stage model for children. We can't do anything with anyone unless if they don't feel safe. We really have to go back to what we were just talking about a minute ago. And kind of take it from there. Education, pharmacology, medications can certainly be very helpful to target their symptoms of depression and anxiety. There isn't anything specific for PTSD, but medications that help with depression and anxiety can be very helpful. Paxil and Zoloft are two antidepressants that are commonly used for PTSD symptoms. So those are SSRIs. And some other medications are off-label, like Nardil, which is a monoamine oxidase inhibitor or an MAO inhibitor. So that can be somewhat helpful. Effexor might be a little bit helpful. Catapres or clonidine is something that I have seen used on 1K, and that can just help some of that hyperarousal symptoms. And minipress is also something else that I have seen. That's an alpha receptor antagonist, used for nightmares and sleep disturbances. I have seen that one used on 1K. Inderal or propranolol, a beta blocker, can also be used for like the hyperarousal and panic symptoms. So, all right. Advanced practice, EMDR therapy. There's just some controversy, I guess, with EMDR. I have seen some articles that say it's great and other articles that say it's really not very scientific. So basically what it is, it's eye movement desensitization and reprocessing. So there's a little paragraph on that on page 301. And I just have read a few articles that just really don't give this a whole lot of credit for actually helping people with this. However, the book really talks about that it is an innovative therapy and that it can be used. Usually it's by the advanced practice professional, and you don't really need to know what it is. It's just something that is, an advanced practice intervention. An advanced practice nurse could certainly be providing EMDR therapy. You may hear of that every now and then, but it has to do with eye movements and having, following a specific protocol, and it's supposed to help the person to integrate these traumatic, to process and integrate these traumatic memories. So I don't know. I guess I would like to do more reading about that, but I just haven't read anything real recently that proclaims this as an excellent therapy for PTSD. There's another stress disorder, trauma-related disorder called acute stress disorder. And that can happen immediately after a highly traumatic event. Usually symptoms are there for about 3 days or so. A diagnosis is made within a month. After a month, you either have resolution of this acute stress disorder or it becomes PTSD. Usually, the person is having problems with concentration, so they can't concentrate. They have anger. They might have some amnesia. They might have headaches, irritability, and nightmares. Adjustment disorder is another diagnosis. And again, this is a medical diagnosis, but as nurses, we're going to be doing the assessments and intervening and evaluating. So we're using the nursing process. Again, precipitated usually by a stressful event, and it just really gives the person very debilitating cognitive, emotional, and behavioral symptoms that just negatively impact their normal functioning. So it really is impaired like immediately. And the responses to the stressful event may include combinations of depression, anxiety, and also disturbances in conduct or their behavior. I used to see this diagnosis a lot, and I'm hardly seeing people diagnosed with this anymore. Not really sure why, but usually it is something that is, if somebody doesn't have any other diagnosable mental illness, such as they don't have schizophrenia, they don't have bipolar, they don't have a major depressive disorder, they don't have any of the anxiety disorders we just talked about, they may be diagnosed with an adjustment disorder because of the way that they're responding to a very stressful event. The thing that's the most different with this, probably than the most different about this than PTSD would be that usually the stressful event isn't quite as traumatic as it would be in PTSD. And usually people have overall pretty good quality of life. They may not need to be in the hospital at all. They may actually just benefit from some outpatient therapy because they may have just like either withdrawal, or they may be angry, they may have some depression, so they definitely need help, may not always need hospitalization, though. Dissociative disorders, they occur after a significant adverse experience or trauma. Usually, it is so significant as to be pretty much horrifying. So I have worked with people with dissociative disorders, especially dissociative identity disorder, which we used to call multiple personality. And usually the trauma that they have been to has been chronic, ongoing, and absolutely horrible, just almost beyond human comprehension. So these individuals respond to that stress with severe interruption of consciousness. It is an unconscious defense mechanism. So again, going back to that video recording of the defense mechanisms, it doesn't happen consciously. You don't force yourself. You don't make yourself dissociate. It just happens because it's the only way that your mind can cope with the horrible thing that's going on. Just a real quick example of dissociating. When I was working back in Rochester, I remember a medical student was talking about how she went jogging through a park that's near the hospital, and she got raped while she was jogging. And she said that she, in thinking about it and talking about it later on, she actually realized that she must have been dissociating during that episode, because she said that she heard someone screaming, and then only later on did she realize that it was her that was screaming. So she must have dissociated during that episode. So it is something that happens on an unconscious level. And it protects that person against overwhelming anxiety through emotional separation. So that's kind of the basis for all of the dissociative disorders. So we have depersonalization, derealization disorder, dissociative amnesia, and again, dissociative identity disorder, which we used to call multiple personality. So depersonalization, the focus is on yourself. It's very uncomfortable feeling of being an observer of your own body or mental processes. So it's like you're kind of outside of yourself. In derealization, the focus is on the outside world. So it's a feeling that your surroundings are unreal or distant. The person might feel mechanical, dreamy, or detached from their body. And so sometimes people have these episodes, and they can kind of come and go with stressors, and eventually it can become constant. So people really do describe those as pretty distressing. Dissociative amnesia is something that can happen when, again, as a result of some kind of a stressful event, and it's the inability to recall important personal information. Like, you might not know your name, you might not remember where you live, you might not even remember that you're married. So it really can be pretty significant. I have an article at my desk that talks about a man in Dallas who had this happen apparently a couple times, and he went missing, and so his wife put up posters all around Dallas, and of what he looked like and that he was missing, and they eventually did find him as a result of her putting up posters of his picture. And he pretty much forgot who he was, forgot that he was married, didn't remember his name, and they weren't really sure how he kind of survived. I think he was missing for a couple of weeks at least, and they found kind of like jelly packets in his coat pocket. So he must have been, perhaps he was going through garbage and finding people's half-eaten McDonald's meals or whatever. They weren't sure. He didn't have any money with him or anything like that, so they weren't really sure how he was eating or what he was eating. He wasn't in horrible condition, medical condition, so he must have been eating and drinking something, but he truly had no recollection of who he was. And people had to identify him, and then through therapy he was able to remember his wife and kind of remember details of his life, but it was precipitated by a stressful event. Dissociative identity disorder, again, that's kind of the most serious of these dissociative disorders, because the person actually splinters off and has usually several different alternative or alter personalities. So usually there's the main host personality, and then you have some alters. So you might be aware of some books or movies that describe dissociative identity disorder. So I read a really good one a couple of years ago, and the book is called The Flock. And I cannot remember who the author is. I could probably look it up if you're interested, or send me an email if you really want me to look that up. But it's called The Flock, Flock, as in a flock of birds or whatever. So it's kind of like this person is describing their many different personalities as like a flock. So it was a fascinating book, and goes through what this person's experience was with her childhood, and then splintering off into all these different personalities, and then coming to therapy. And she had a really unusual therapist who really employed some really different types of techniques, and actually almost reparented this girl to bring her personalities all together. And it took probably 6 or 7 years in order for this person to become better. It really is very long, intensive therapy. It's not easy to get that person all back into one whole person again, but it is possible. And again, that would be an advanced practice intervention, or a psychiatrist, psychologist, or a psychiatric nurse practitioner could certainly work with somebody with this disorder. But one of the things I remember in that book that was just fascinating was a couple of the personalities were out at the same time when this person was going to college. It sounds like she was probably pretty brilliant, because she was going to Ivy League colleges. And once she was sitting in a classroom taking notes, and two of the personalities apparently were out at the same time, because they each had different skill sets. And one of them was taking notes with the right hand, and the other was taking notes with the left hand at the same time. And one of the personalities kind of said to the other, we better stop this because people are looking at us funny. So I just always remember that. And there can be certainly a lot of different types of behaviors, especially when different personalities are out. The personalities can, just from my own experience, the personalities can be male, female. They can be of any different sexual orientation. They can be a child. Even if the host personality is a male, they can have female personalities, or vice versa. It really is kind of an interesting experience. And I've often seen too in practice, when I'm working with these patients, that many times there is one personality that usually is very destructive and wants to commit suicide and kill all of the personalities. So that's a really difficult challenge, because perhaps the host personality doesn't want to commit suicide and really wants to get better, but that one personality is in there and usually is very self-destructive. Or homicidal. I've actually seen that too, where the one personality really wanted to kill other people. So really creates a challenge, even if you're even if you're not the advanced practice nurse. If you're the staff nurse working with a patient like this, really does present a challenge for working with this person. Many times what we do is you start out introducing yourself and then asking, who am I talking to right now? Especially once the person is aware of their different personalities, and they'll tell you. They're usually very open, and they'll tell you what their name is, and they'll tell you who's out at the time, and maybe perhaps another time you're going to interact with them, and you're going to get a really different feeling from that person. The way they look at you, their eye contact is really different, and maybe even the tone of their voice is completely different. So again, it's appropriate to say, who am I talking to right now? And they may give you another name that's completely different from their actual name. So it really is a challenge working with these patients. So probably the biggest thing to remember with dissociative identity disorder is they truly have had horrible lives. They have been victims of terrible, unrelenting trauma. There's another book too, if about trauma, and I don't know if that person actually developed a dissociative identity, but he probably should have. I believe it's a boy called It. I don't know if any of you have ever read that, but if that isn't what he went through, if that wasn't a setup for a dissociative identity disorder, I don't know what is, because the trauma and the things that he went through were pretty horrendous. So usually they're going through things that are just really, truly above and beyond human comprehension. So many of their behaviors too are just very difficult to deal with, again, because of the self-destructiveness, and oftentimes the personalities have different, some of the personalities are quiet, they just have different aspects to themselves. Some might be more quiet, withdrawn, prim and proper, and there might be a personality that might be more gregarious, friendly, outgoing, flashy in their dress, sexually promiscuous. So again, lots of potential for different behaviors and different problems. So it is, again, it's a defense mechanism of dissociation. So that's the main thing going on there, that overwhelming trauma. And certain native groups might have culture-bound disorders, which are different from dissociation. So we always have to think about that cultural aspect. Again, going back to depersonalization, again, focus on self, derealization, focus on the outside world, just a review of what I had said before. Dissociative amnesia, again, inability to recall important personal information, like, again, being married, what your name is, what your job is, things like that. A dissociative fugue is a subtype of dissociative amnesia. I have seen a few people that were in a fugue state. And actually, when I worked in the psychiatric emergency room in Rochester, there were a few patients that seemed to be in a fugue state that just took a bus and ended up in our emergency room. And they had no idea who they were or where they were from. They didn't know what state they lived in. And it was really interesting to try to figure out who they were and where they came from, and trying to get some medical record history on them and trying to get them back to, to where they belonged. So, and that's usually sudden, unexpected travel. So they get on a bus and they just go somewhere, and they don't know where they're going, they don't plan it, and they just arrive somewhere, and they don't know who they are or their name or any information, who their family members are. It's really kind of interesting. Not real usual, but definitely interesting. Okay, so back to, again, describing that dissociative identity, two or more distinct personalities. They each have their own patterns, and again, the history is severe trauma. Their moods can really fluctuate. Depression, anxiety, things like that are really very common. Being suicidal, that suicide risk is really huge. The impact on the patient, of course, is awful, because the patient really has a hard time navigating through life, and going to school and having a career, developing relationships are extremely difficult unless they go through years of therapy to try to integrate back into one particular person again. The self-assessment is what we have to do when we work with somebody like this. There are medical professionals that don't believe that this is a real diagnosis, and they really don't. They think they're faking it, they're putting it on, they're pretending, they're making up the personalities, they're acting. Truly, I can see where people can think that, because it really is a very, very unusual, hard to explain diagnosis. There's a couple of movies actually out there that are about dissociative identity disorder also, and Three Faces of Eve, Sybil, some of those are some older ones. There's probably some more recent ones too, but because of that too, you look at the Hollywood aspect, and many people think either just normal people in the outside world, or even some medical professionals just think, oh, this can't be real. So we really do have to do that self-assessment. And honestly, I totally believe it's real. I have worked with enough patients that have this disorder. Maybe in clinical, I can tell you a couple more stories about working with people with this disorder, but it absolutely is real, and it is kind of frightening sometimes when they come out as a different personality. It's just It's very interesting. But anyways, we do have to do that self-assessment and make sure that we have, an understanding of the illness, and also make sure that our personal feelings aren't getting in the way of caring for the patient. So a little comic strip about this, me and the alters, and that's pretty much what it is. They can be male, female, different ages. They can be children. They can have completely different occupations. Perhaps one could be an artist and another could be a mathematician. It really is quite interesting. Okay, and this is just really a silly comic. Doctor, your client with the multiple personality disorder is on lines 1, 2, 3, and 4. Really isn't anything to make fun of, but sometimes a little humor just helps you to kind of remember things, and just we always need to remember to respect patients when they have different mental illness disorders going on. We always want to do establishing safety, stabilization, and reduce their symptoms. And of course, we can't control when they're in the hospital, we can't control them changing back and forth from different personalities, going back and forth from one to another, but we certainly can try to control the overall depression, anxiety, and suicidal ideation. We really want to help them overall work through their traumatic memories, but that is really save that one for the advanced practice nurse or the psychiatrist. We don't want to do that as a staff nurse, going over their traumas and having them talk about their traumatic experiences. If you don't have the skills to deal with that, we really shouldn't be doing that as staff nurses. So phase 3, again, the advanced practice person would be helping them to integrate back into one person and get rid of all the alter personalities, and then rehabilitation and helping them to become a functional human being. So education is very important. We certainly can teach patients about their illness. Pharmacological, again, would be there's nothing specific for dissociative identity. However, medications to help treat their symptoms could be very helpful, especially their depression and their anxiety, and many, many different types of therapies for that the advanced practice nurse would be doing. Okay, an audience response question. A nurse assesses a patient diagnosed with dissociative identity disorder, which finding would be likely part of the patient's history, travel to a foreign country, physical or sexual abuse, thyroid dysfunction, or an eating disorder. So that's a little bit of a trick question. So I'm hoping that you picked physical or sexual abuse, but actually eating disorders are also highly associated with dissociative identity disorder. I've worked with several patients in the past that have both. So it's not unusual that they would have that history. So that's a little bit, I won't have any trick questions on the test, I promise you that. But maybe some hard questions, maybe some easier questions, but not a trick question. I kind of think that's a little bit of a trick, because truly I do see a lot of correlation with eating disorders and dissociative identity, but usually you are going to find some kind of abuse as far as their history. Okay, the somatic symptom disorders. So, a little case study. Mr. Brazzelli is brought to the emergency department by a cab driver who walks with him into the entrance and says, "This guy says he just lost his sight. He just went blind after he got into my cab." Mr. Brazzelli is very patient and says during assessment, "Well, I've had several episodes like this. I guess this just happens sometimes." So, interesting. I wonder how many people, if they just lost their sight, would actually be so nonchalant about that. But actually, that is very characteristic. So, during assessment, Mr. Brazzelli says that when these episodes of blindness come over him, it immediately follows after an epileptic fit. Testing, however, shows no signs of seizure. The ED physician records that Mr. Brazzelli has neurologic symptoms, but in the absence of a neurologic diagnosis. He also makes note of this patient's lack of distress about what should be an alarming condition. So all of these things are very, very characteristic. Somatization itself, just generally, somatization means the expression of stress through physical symptoms that are manifestations of psychological and emotional distress. So that's what somatization is. You're going to hear that word a lot in mental health. So you're going to hear that, oh, that patient is very somatic. You might hear that a little bit in the medical side too, but I think we really tend to use that a lot in mental health. That person is somaticizing, and it can be actually, you can somaticize with almost any illness. So people that have anxiety somaticize, people that have depression sometimes somaticize, and that just means that they're really expressing their psychological distress through physical symptoms. So some very common complaints that they might have would be headaches, stomach aches, backaches, different types of pain. It could be muscle pain, anywhere, it could be anywhere in the body. So those are some really typical GI distress, nausea, vomiting, stuff like that. Those are real typical somatic types of symptoms. So, and those symptoms are expressed in place of anxiety, depression, or irritability. So they really don't openly talk about their feelings. They can't rate their anxiety on a scale of 1 to 10. It's almost like they don't really realize that it's existing, or they don't talk about how sad they're feeling or irritability. So it's they're somaticizing in place of that expression. Really need a holistic approach with these patients. So it's multidimensional interplay of biological, psychological, and sociocultural needs and its effects on somatization. So it really is helpful for us to have an understanding of why this happens, because people that are somatic can be very frustrating to work with. Sometimes it's like you just want to tell them, it's all in your head. It's not real. It's not really happening. You don't really have this physical problem. But for them, whatever they're experiencing is really quite real. So the clinical picture, we're going to look at several different disorders: somatic symptom disorder, illness anxiety disorder, conversion, which is actually what the little case study about Mr. Brazelli was all about, psychological factors affecting a medical condition, and factitious disorder. So we're going to kind of be looking at these briefly. So somatic symptom disorder. You usually have one or more distressing symptoms. You may have excessive thoughts, anxiety, and behaviors around those symptoms or health concerns. So they tend to be very preoccupied and worried about their health. And some of the symptoms that they might complain about would be pain, fatigue, dizziness, headache, swelling, back pain, shortness of breath, insomnia, abdominal pain, numbness, things like that, but without significant physical findings and a medical diagnosis. So there might be some minor physical findings, but certainly not enough to warrant their complaints. So there really isn't a medical diagnosis that will account for their symptoms. But we have to understand their suffering is very much authentic. It is real for them. And they do have a high level of functional impairment. They do tend to spend much time looking for help and going to doctors and going to different doctors and just keep trying to focus on getting help for something that they feel is really quite real. Illness anxiety disorder is misinterpretation of physical sensations, preoccupation with having or acquiring serious illness for at least 6 months. They have a high anxiety about their health, and they have excessive health-related behaviors or maladaptive avoidance. So they may be care-seeking or actually care-avoidant. Well, this disorder used to be called hypochondriasis. So you may be familiar with the term a hypochondriac. That is something that is kind of commonly used in our everyday language. So basically the person who is constantly thinking that there is something wrong with them. So this person usually, you can be care seeking or care avoidant. Usually when they're seeking care, they are wanting something, they are wanting a treatment. So the person who is sneezing and they go to the doctor and they really want an antibiotic because they really feel they've got pneumonia. So it actually has kind of a compulsive quality to it also, and they really are they have high anxiety about their health. They really are very very focused on their health, and they have a hard time really accomplishing anything else in their life. They're so very focused on their health. So okay, a little comic, a little humor. The Hypochondriac Society, our guest speaker called in sick. Okay, that would be probably pretty typical. Anyways, conversion disorder. So again, going back to that case study at the very beginning of this chapter, neurologic symptoms in the absence of a neurologic diagnosis, presence of deficits in voluntary motor or sensory functions. So usually what we're thinking about, the case study was talking about, the little case study at the beginning was talking about the guy who was in a cab and went blind. So usually paralysis, blindness, movement and gait disorders, numbness, paresthesias, loss of vision or hearing, or episodes resembling epilepsy, so pseudo seizures. And they have that labile indifférence, which means basically that in the very first description of Mr. Brazelli when he was getting out of the cab, and the cab driver was saying he's not even worried about his blindness, and he seemed very matter-of-fact about it. That is absolutely typical, and that's called labile indifférence versus distress. So they're not distressed about their symptoms, and you would think they would be. You would think that if you all of a sudden were blind, you would kind of be distressed about that. So I have a little story about this. I actually took care of a person in the hospital long time ago, who had a conversion disorder, and her conversion was that she could not walk and she was in a wheelchair. And it was actually somebody who had attended the same college that I did. I didn't know her, and she was not a nursing major. She was in some other field. But anyways, I just remember seeing her on campus because it was a pretty small campus, so everybody kind of knew who each other was. And she was just very loud and very friendly and just always laughing and talking to people. Just seemed like a kind of a social butterfly kind of person. I didn't really know her though. And anyways, so here she is in the hospital, and she's in a wheelchair, and she's in her 20s, and she is absolutely not the least bit concerned about this. So she is just whipping herself all over the unit in that wheelchair and wheeling herself all over, going up to the phone, ordering pizza for everybody on the unit, just being kind of, again, her typical friendly self that I remembered, and not the least bit concerned that she couldn't walk. So it really does happen. You might think, oh, come on, really? It actually does happen. That is one of the hallmark symptoms of having the conversion disorder. So you might think, well, why? Why would you not be concerned about losing your vision, losing your ability to walk? Well, going back to that, again, that recording of of all those defense mechanisms, when you have something like conversion going on, all of your stresses and anxieties are all bound up and wrapped up in that one symptom. And you don't have to feel any anxiety or concern because it's all in that symptom. So it kind of like the conversion actually takes care of all the feelings and anxieties that you would be feeling about some stressful thing going on in your life. I don't remember what it was that was a stressor in her life. Maybe it was just being in your 20s and graduating from college, and now what do I do? Finding a job. It could have been all of that, but it could have been something more going on in her personal life, and I don't remember that. But anyways, so we really do have to understand that this is something that it is real. I have seen people with, again, I have seen the the temporary loss of hearing also, and also pseudo seizures. I've seen a lot of patients with pseudo seizures, and that can be difficult to actually tell the difference between a real seizure and a pseudo seizure. But again, we have to go by actual neurologic findings and their history. So, psychological factors affecting a medical condition. So we have to think about how psychological factors can increase the risk for medical diseases, magnify them, or interfere with their treatment. So this really is kind of a slide basically about comorbidities. So if we think about how if you have a medical diagnosis, if you're having stress and you have psychological factors that are going on, things that are really stressful, then that is going to usually worsen your medical condition. There's actually a lot of research being done on the links between depression and cancer and cardiovascular diseases, so that is being studied. And this is a really important statement in your book where they talk about depression being such a powerful condition that it's associated with increased risk of death from nearly all major medical causes. So we really have to put a lot of importance on understanding depression and encouraging people to seek treatment for this. Stress, of course, affects medical conditions, and it, again, going back to kind of what we talked about at the very beginning of this learning plan, when we think about Hans Selye and all the different theorists that talk about the effect of stress on the body, of course, again, this is all about comorbidities, and of course we have to take a look at the relationship between the body and the mind and how stress really does work to increase, usually exacerbate the illness. You may have some experience already in dealing with patients that are undergoing stress, perhaps at work or in a medical setting. Even if you have never set foot in a mental health unit, you've probably seen the effect of stress on patients and they're getting well, or patients who might not get well as quickly because perhaps they don't have a support system or they have lots of different stressors going on that are affecting them getting better. Okay, an audience response question. Which diagnosis best describes Mr. Brazelli's condition? Psychological factors affecting medical condition, SSD, which is somatic symptom disorder, illness anxiety disorder, or a conversion disorder? So I'm hoping that you said conversion disorder. Okay, so when we're assessing people that have these disorders, we're looking at their psychosocial factors. What are their coping skills, usually, if they have any spirituality and religious beliefs that are either helpful or hindering their recovery. If they were looking for any secondary gains. So you're probably thinking, what in the world is secondary gains? And that's usually, it's kind of like the goodies that you get from being sick. So, for example, if you break your leg and you're on crutches, there are certain things that you probably can't do. So it's like, oh good, now somebody else can cut the grass. I can't do it because I broke my leg. So that's kind of like a secondary gain. So if somebody has a conversion disorder and they're in a wheelchair, they are going to be excused from certain things. Or if they have that blindness in their conversion disorder, well, they can't see, so how can they be writing out checks and paying the bills? So it's like they get out of tasks and duties that they normally would do, and they may get some extra attention from people. So they're going to get visitors, cards, phone calls, flowers, gifts, things like that. So anything that kind of gives them like goodies from staying sick is kind of what we call secondary gains. We have to look at their cognitive style, just what is their style of thinking, feeling, relating, behaving, their ability to communicate their feelings, their emotional needs, if they communicate easily or if they just really are in denial of their feelings and don't communicate those well verbally. So, people that don't communicate verbally, usually those symptoms and those feelings are going to go somewhere. So that's many times they turn into somatic symptoms. If they're dependent on medication, if they use medications at all, if they're using them appropriately or inappropriately, and again, we always have to do a self-assessment because these patients can be very frustrating to work with. We've had the experience of working with a couple of patients in the last few years in clinical that have had somatic disorders. Very, very interesting, very challenging. There was one young man who was only in his 20s and really felt like there was something physically wrong with him, and we just needed to get to the root of what his physical problem was, and then he'd be all better. And he had a thorough physical workup because truly we don't want to ignore somebody's physical problems if they actually do have something real going on. So truly, as a nurse, we should be advocating that these patients do get a workup. Okay, that is really an important thing to think about with these patients. They absolutely need a workup. And when the workup comes back negative, then that's where we can try to help the patient, do some teaching, and try to help them to cope in some different ways. But they can be very frustrating to work with because this one young man wanted us to take his blood pressure like 6 times a day because he was so worried about and just knew that something was going on with him and that his heart was going to stop. He didn't even want to sleep because he thought his heart was going to stop while he was sleeping. Wanted us to continually be checking his blood pressure. And so we really had to put a stop to people obsessively, taking his blood pressure anytime he asked, because it really truly wasn't therapeutic. It was just really feeding into his thinking there was something physically wrong with him. And so we would try to direct him to other ways of coping and expressing his feelings. So very, very frustrating sometimes to work with. An example of some nursing diagnoses that would apply to patients that have these diagnoses: ineffective coping, absolutely. Anxiety, risk for loneliness. Sometimes they're so focused on their physical illnesses and ailments and feelings that they really are not engaged in relationships. They're not socializing. They're not going to work, perhaps. Family relationships can be difficult. Powerlessness, hopelessness, social isolation, pain, altered family processes, and certainly risk for suicide. We always want to look at our outcomes and our goals for the patient. So really, we should be focusing on shared decision making. We should not be just telling the patient what to do and making a goal for the patient. We really need to involve the patient and encourage their participation in setting realistic goals. They really should be realistic and attainable. And these patients we need to work within very, very small steps. And it's nice when the patient can see concrete evidence of progress by taking those very small steps. So the implementation, first and foremost, always establish that therapeutic relationship, educate the patient regarding treatment and regarding their illness. I just want to mention this too quickly, that in the olden days, patients were never told their diagnosis. If they had depression, anxiety, schizophrenia, bipolar, whatever they had, a somatic disorder, they never were informed of their diagnosis. And we as a nurse should not be telling a patient their diagnosis for the first time. That certainly is up to the physician, but we can be reinforcing information about the diagnosis to that patient. So education is definitely a big part of what we do as nurses. We can refer them to support groups, but again, just make sure if it's an online support group, just kind of make sure that it is actually something that's valid, or if it's a face-to-face support group, that would be probably probably the best thing. You just really have to be careful of some of the online support groups. Teach effective ways to cope and focus on their strengths as a person and reinforce the skills that they do have. So again, very important. We want to try to focus off of their symptoms sometimes. Yes, we have to do a little bit of an assessment and make sure that there really isn't something, going on with that patient. So to check that guy's blood pressure once, fine, but we don't need to check it 6 times. That's not therapeutic, but certainly to check it once. So do an assessment and then focus on the patient as a person. Find out from them, what are their interests, what are things that they feel that they're good at, and really try to build on those. Really, really important for us to do that. So 6 key elements for effective treatment: continuity of care. So again, as much continuity as possible, assigning the same caregivers, avoiding unnecessary procedures. Again, advocating that they get a good workup is wonderful, but we don't want to have continuation of unnecessary procedures if it's already determined that they don't have an actual medical condition accounting for their symptoms. Brief, frequent, regular contacts with them. Always conduct a physical exam and avoid disparaging comments. We really don't want to tell somebody, it's all in your head. You're not really dizzy. You're not really nauseous. It's really hard to not do that sometimes. Again, this young gentleman who thought he had this cardiac condition also sometimes would come out of his room kind of gagging and dry heaving and like he was going to be, throwing up all over the place. And it was really difficult sometimes for the staff to deal with him therapeutically and just try to redirect him to go back to his room. But I just remember sometimes overhearing some of the comments to him, and they were really kind of frustrated that he was out in the hallway kind of gagging, and they were worried he was going to, throw up on the carpet in the middle of the hallway or something. So it's easy sometimes to say things that just are really can be interpreted as kind of unkind to the patient. So really important to watch what we say and make sure that we're being therapeutic, and again, to set really therapeutic, reasonable goals that are attainable for the patient. Nothing would be worse than trying to set a goal for somebody that they just couldn't possibly attain. So again, some more psychosocial interventions. Going through coping strategies that preclude somatization. So how did they used to cope with stress in the past? And, somatization is kind of a way to cope with their stress, but it's not a healthy way. We really want to help them to promote self-care activities also, to get into a good daily routine. Showering, brushing their teeth, and again, those are very simple, basic things. Sleeping, eating appropriate, drinking appropriate amounts of fluids, all those things are just really helpful as far as basics, as far as helping the patient to feel better. Assertiveness training, actually helping them to understand and express their feelings in appropriate ways, especially when things are difficult. So it's hard to be assertive when you feel like people are overpowering or aggressive to you. Some people just don't know how to respond to that. So teaching ways to respond when things are difficult is very helpful. Medications, again, really usually to target symptoms of depression or anxiety. Health teaching and health promotion is always within our realm. People might need case management, especially if they are seeing multiple different types of caregivers, so somebody to really coordinate their care. It's honestly better for somebody with any of these somatic type disorders really to be seen and have a good relationship with one care provider, whether if that's a physician or if it's a psychiatrist, psychologist, a nurse practitioner, but usually to try to get a really good rapport with one person rather than going to multiple different doctors. So that would be maybe a goal that case management could kind of work on. So advanced practice interventions would be doing some psychotherapy or consultation, using that holistic approach, cognitive behavior therapy, or possibly being a nurse consultant or a liaison. So, evaluation based on clear, realistic, measurable outcomes. The goals are often reported as only partially met. It really is difficult for patients to overcome these types of illnesses. Again, it's not hopeless, it just really does take a lot of work and a lot of time. So, patients often report continuing somatic symptoms, but they may report less concern about them. So, actually, that would be a bit of a positive outcome, or at least the goal is partially met if they're having less concern about their somatic symptom. Factitious disorder. People that have this disorder artificially, deliberately, and dramatically fabricate symptoms or self-inflict injury. I have seen patients with this disorder in the hospital. I actually saw one when I used to do med-surg clinical long time ago, and they actually it was actually a married couple, and sometimes the husband would come in and he would have injected himself with using a dirty needle, just with saline, like into his leg or his hip, and of course develop an abscess and have to come in for antibiotic therapy. And then he'd get better and go home, and then his wife would come in and she would have injected herself with a dirty needle and normal saline and just, into a pocket in her hip or her thigh, and develop an abscess or cellulitis and need IV antibiotic therapy. So basically, it used to be called, it's kind of an older term, is called Munchausen's disorder, so you may have heard of that, but really the true name of the disorder is factitious disorder. So the goal is by dramatically fabricating these symptoms and doing things to self-inflict injury on yourself, the goal really is to assume the sick role and that other people are taking care of you. So you are being cared for and being given that attention and concern from the health professionals. It absolutely has a compulsive quality to it because people do it usually it's chronically, it's done chronically. They do it over and over again. It's not like you just do it once and it's over and done with. It's something that is very, very ongoing. And in this one particular couple, it was interesting because it was a married couple, and one would get better and they would, go home, and then the other one would end up in the hospital, and then they would go home, get better, and then the other one would end up in. So it was very interesting how it kind of worked in their marriage system. So you might be thinking, well, if a person has this disorder, it really is very costly. And yes, it is. It really does cost the healthcare system a lot of money, because people are purposely tampering with their bodies in different ways and ending up in the hospital needing care and treatments. So yes, it is actually very expensive, and also it is very difficult for them to really to carry out on jobs, to uphold jobs, and even do things around their house, to be a functioning person in society really can be very difficult. So there's two types of factitious disorder. First is imposed on yourself, and second would be factitious disorder imposed on another, which again we used to refer to, commonly known as Munchausen's by proxy, in which usually it's a parent who is inflicting injury on their child. So those two, very interesting. Factitious disorder imposed on another. I was teaching class this past semester, and some students brought to my attention somebody by the name of Gypsy Rose. And I'm not sure if I put that video in your learning plan or not, but if not, I'll try to find one. If not, otherwise, you can just, if you Google Gypsy Rose, you will read a very interesting story about a girl who, her mom basically was the one who was the perpetrator, and she basically told her daughter that she was sick, that she couldn't walk, that she had cancer, that she had all these illnesses. And so this girl was kind of grew up in a wheelchair and undergoing all different types of medical treatments. And it ended up that this girl had a boyfriend later on in her life in her teenage years or young adult years, I don't remember which exactly, and ended up planning the murder of her mother. So it's really quite interesting. It's a true story. That is a pretty extreme example of Munchausen's by proxy. But basically, it is a form of child abuse also. That is something that we need to kind of realize as nurses. So it's either imposed on self, imposed on another. Malingering is another type of factitious disorder. And basically, when you have malingering, usually there is something real that was going on. But if you know what the phrase milking it for all it's worth means, that's kind of what it is. So you might have, again, a broken leg. And so you get out of different things that maybe you don't like to do. So now it's summertime and you don't really like mowing the lawn that much. So, oh, good. So I broke my leg. Now I don't have to do the lawn. Well, your leg is healing and you're able to walk now. But it's like, oh, no, my leg still really hurts. I can't do the lawn yet. So it's like you're just trying to prolong the positive benefits of having that that disability. That's kind of what malingering is. So it just goes on for way longer than it really should. Just to summarize then, malingering is related to the factitious disorders. It is conscious fabrication of illness or exaggerated symptoms again. So something real did happen, but you're milking it for all it's worth for secondary gains. And sometimes the secondary gains could be insurance fraud, prescription medication. So sometimes people want to continue to get their narcotic pain relievers, avoidance of prison, avoidance of military service, or actually your book also talks about sometimes people actually wanting to apply for disability, and they will continue to exaggerate symptoms in order to become disabled, to get that disability funding. So those are all things that we have to think about. So again, boy, doing that self-assessment, it really can be very frustrating when we know that somebody isn't really truly suffering, that they're really fabricating things in order to get some secondary gains. So can be very frustrating. Okay, but just a little comic relief. Hi, Doc, I could be malingering, and then again, I might be the real article. I leave it up to you to decide. Very frustrating for medical professionals sometimes to work with people that are like this. Oh, and here's Gypsy Rose. I forgot that I added a little picture of her in here. So again, one of the most dramatic episodes of Munchausen's by proxy that I've ever seen. So it looks like she's probably like hooked up to an EEG machine, and she's got a big smile on her face. But boy, reading through her history and what she went through is really, really quite interesting. And very sad, of course. Application of the nursing process. Again, we're always assessing, making our nursing diagnosis. It's hard sometimes, but we have to try to determine if the symptoms are conscious or unconscious. Yeah, it is. It's very, very challenging to do that. We can't really confront people. We really don't want to make people defensive or feel angry, because honestly, some of this does happen on a subconscious level, especially the conversion type of disorders. Again, self-assessment, frustration, we might have some of that counter-transference reaction. Perhaps the patient reminds us of somebody that in our past or in our own life, and that we may be responding in more of a frustrated manner because of that counter-transference reaction. Planning and implementation, we always want to monitor for safety. Again, preventing dangerous, unnecessary treatments. And honestly, if you look at the history of Gypsy Rose and what she went through and all the different types of treatments and things, it is just fascinating to me that a medical doctor would have gone through with prescribing all these different types of tests and treatments when they weren't really warranted, because by the time that she met this boyfriend, and she was kind of ran away with him, or tried to run away with him, and before they killed her mother, she was able to walk. She just got up and walked out of that wheelchair. So I just don't know how a doctor would have gone through and given her all those different types of tests and treatments. It's just kind of mind-boggling. I guess I should read a little bit more about that. But anyways, again, part of the nursing process, we always are evaluating our interventions. We certainly want to teach people new coping strategies, and that would be the ultimate goal, would be that we see them cope more effectively. Little audience response question: which is an example of malingering? Mr. Harris injures his foot to avoid military service. Mrs. Adams has been making her child vomit and lose weight to pretend he has cancer. Mr. Singleton has difficulty walking and uses a wheelchair, but without neurologic deficits, which began 2 months after the death of his wife of 32 years. Mr. Monini frequently calls or comes to the clinic in a panic, believing Ms. Monini, sorry, I thought I said Mr., believing she is ill. Her suffering is genuine, but she never has any concrete signs of any illness. So I'm hoping that you said the example of malingering is A. And then if we go through the rest of those, B is Munchausen's by proxy. So C would be a conversion, an example of a conversion disorder. And D would be an example of the illness anxiety disorder. Which is an example of illness anxiety disorder? Oh, I think I just told you in the other slide. Okay, well, anyways, I think it's time to end this learning plan, and I hope you found it interesting, and the next learning plan will be on mood disorders.